Hello, my name's Kathleen Insel, and I'll be talking about how we can figure out whether or not it's cognitive decline or it's delirium that we're looking at, depression, or dementia. There are a number of factors that can lead to cognitive change among older adults, and I think that these things can be very confusing because they also can overlap. And so people who have dementia can also have some delirium, and people who have cognitive decline can also be depressed, and it can augment what you're seeing. So I think it's very important to understand what the options are and to try to figure out what's going on, since a couple of them are reversible if we do the right things. I just want to focus your attention for just a moment on a newspaper article that I saw, the front page of the New York Times on Sunday. An early sign of Alzheimer's brings fear and new insight. There's a tremendous amount of emphasis, I find, more recent literature, looking at our baby boom generation, of which I'm part of, and looking at, kind of how these things are being played out within this generation. There's more attention to it. We've kind of driven the media, I think, our generation has over time. So it's not surprising that this should be happening, but either because I'm sensitive to seeing these things, so I'm more perceptive about picking them up, or there is a greater prevalence of articles related to dementia and to Alzheimer's. I find that there's a great deal out there in the literature and the lay public. This article was also followed up with one in USA Today on Monday morning then. And one of the things it was talking about here is there's a man named Peterson who works at the Mayo Clinic in Minnesota, and he has discovered that mild cognitive impairment, which is defined as one standard deviation below your age and education matched norms, is predictive of the onset of Alzheimer's later on. So that's fairly powerful. So people are getting a diagnosis, a preliminary diagnosis, prior to the loss of awareness. Mm. And there are several things that are, I think, new issues because of that. What do people do when they try to deal with that? How important is memory to our humanness? So those are the kinds of things that I'm going to be talking about. I've already talked about the headlines that I'm seeing, in our baby boom generation that are making perhaps this more obvious in the literature. There are cognitive changes that occur with normal aging. There are specifically changes that occur in working memory and executive function. I'll be talking a little bit more about those things. And I want to know and be able to help you understand how we can distinguish between normal changes, delirium, depression, and dementia, since all of those factors can lead to some cognitive changes. So human memory defines, I believe, who we are as people. There's nothing more fascinating to me than our understandings of ourselves, our stories, what we bring, our ability even to prepare a meal or to shop for food, our vocabulary, the pleasure that our memories bring to us. All of that is related to our ability to have these memories. And if we think about the things that we forget, we think sometimes that there are a lot of things that we forget, that we engage in a course of study like you're doing right now, and that sometimes I feel like my brain is a sieve and it's all just going through. But think about all the things that you have remembered. I think that there are many things that we take for granted. Our understanding of what to do when we walk in a restaurant, our understanding of the scripts, in normal kinds of social contexts, our ability to converse socially with people whom we don't know, who we don't share any memory with. All of those things are abilities because of our memories. Mental maps, knowing where to get from place to place, face recognition, odors and tastes, the number of windows on the front of the house that you lived in when you were a child. Can you think back right now and think about how many windows you had on the front of your house? Many of us have a picture of that house or those houses and can think about those things. The name of Roy Rogers' horse. How many memories you have stored in your mind that are very helpful to our abilities to function in a daily way. Now, I don't want you to write these down. Just try to remember them. Mm-hmm. I'm going to read them to you. Bed, rest, awake, tired, dream, wake, snooze, blanket, doze, slumber, snore, nap, peace, yawn, drowsy. Now, let me just ask you, was door on the list?
No.
Right. Was bed on the list?
Yes.
Yeah. Was pillow on the list?
No.
No. Was nap on the list?
Yes.
Yes, I think it was. Was vegetable on the list?
No.
No. Was sleep on the list?
Yes.
See, that's a trick I play on people. And I apologize for doing that, but it points out one of the things that we must understand about memory when we're working with older people. Memory is reconstructed. We get gists of what the story was. All the words on that list, or most of the words on that list, were related to sleep. So it led us to believe that sleep was on the list. Sleep was not on the list. But yet I made the same mistake. I fell into the same trap. Because memories are not like videotapes. We can't replay them. Memories are not literal translation of events, which makes understanding whether or not someone is having a deficit in memory a little bit more difficult, because we don't expect people to remember word for word. We don't expect people to remember everything. It's just not part of what our expectations would be. So also, I wanted to do that demonstration to point out to you that forgetting is normal at all ages. The mere fact of forgetting or not reconstructing absolutely, veridical to what the reality was, doesn't mean that we are experiencing any kind of problems, okay? So forgetting is normal at all ages. And while it is normal, it does increase with age. So we do have more problems as we get older. There have been some alternative explanations for that. So some people think because there are differences between young adults and older adults on how much we can retain, that it's because younger adults are more able to focus their attention. They are less distracted by irrelevant information, whereas maybe older adults are not only listening to the speech that I'm giving right now, but also thinking about, oh gee, I'm getting hungry, what am I going to make for dinner, got to make arrangements to pick up the kids or something like that. All of those things are going on in your minds at the same time. So maybe it's a question of limited capacity or having too much information. So you could argue that, but the truth is that in the laboratory, working memory span does decrease over the lifespan. So if we think about, oops, sorry about that, I really did not want that to happen. How come I don't have control of this? Oh, geez. Okay, so if we think about George Miller's magic number 7, what that is in 1950, George Miller discovered that most people can retain 7 items in their short-term memory stores, plus or minus 2. So that's one of the reasons why our phone numbers are 7 digits. Didn't know if you were aware of that, but that's the case. So they started off being 5 digits when I was a child, but time does change things, and I don't know, I hope we don't have to go much beyond 7, because the human memory capacity, short-term memory capacity, really doesn't hold well more than 7 items, or 7 to 9 items, 5 to 9 items. But as you can see, over the lifespan, as people get older, 25, 35, 45, 55, the number of items that you can hold at one time decreases. And it's particularly compelling in the older age groups. So there is clear evidence that memory abilities, working memory abilities, do change with time. So, oh, yeah, okay. We have to hold more information. Those items that are bolded are the kinds of things that I want you to think about in terms of working memory: holding information, manipulating the information, screening out irrelevant information, and then continuing to take in relevant information. And that requires attention to new incoming information. And that's one of the things also that we see change with age, is that older adults are less able to screen out distracting information, irrelevant information. Okay? We also see that there are time of day effects. So, while you're trying to figure out if someone is experiencing delirium or just age-related cognitive decline or it's dementia, you're also going to be seeing some differences in terms of the way people respond, their cognitive abilities in the morning or afternoon. Most older adults will tell you. Now, the black are the younger folks, and the striped are the older adults on these bar charts, on this bar chart. So percentage of people is on the left. And then definitely morning, 20% of older adults say that they're definitely morning people, that they have better cognitive skills in the morning. Moderately morning, 53%. So now we've got a total of 73% of older adults who say that they prefer morning, okay? And only 5% of younger adults. Neither, younger adults seem to have a preference for neither. And then moderately evening, you're much more apt to find younger people who are saying that they're evening or night people than you have older adults. So it also depends upon when you're talking to people, when you're looking at them, the decisions that you're making about what their cognitive abilities are. There are some alertness factors that are related to the circadian rhythm. So what do we mean by age-related cognitive change? And I wanted to define this at the outset because age-related cognitive decline is a little bit of a slippery concept, and it's very much unrecognized in our healthcare provider realm. So I find that both physicians, nurses, social workers are not necessarily aware that there are normal changes with age, So what do we mean by age-related cognitive decline? Where do we see these changes? We see them in capacity, so changes in working memory, how many balls we can keep in the air at the same time. You know, you could keep many, I used to be able to keep many more balls in the air when I was in my 20s than I can now. I just can't. Speed of new learning and recall. It's much harder for an older adult to learn new skills. So to learn how to work the computer. And there is a point at which they just give up. They don't want to try it because it's just too hard to learn it. It takes just more mental energy. Self-initiation. As we age, we don't necessarily, what they found in the laboratory is that we don't necessarily use strategies spontaneously. So people have thought, well, that may not be due to any age relationships, but also to cohort effects. So if you are a college student, and you know when they're comparing young adults, they're often comparing college students. If you're a college student, you're used to using strategies. You're used to creating a mnemonic device, or you're used to thinking about associating what you're learning with something else that you already know. If you are out of that habit, you know, that may make the difference. It may not be that we don't see the self-initiation going on. It may be that there are just cohort effects here. I hope that's clear. And also our ability to inhibit information changes as we get older. It's just easier to be distracted by irrelevant information. So I have found that people in the office will be looking at the photos, you know, on the healthcare providers, you know, bureau or something like that, or their desk, and thinking about, gee, he has a family, you know, and I wonder what that's like for them, and wanting to talk to him about his family, wanting to get his personal story or her personal story. You know, at the same time, they are not taking in as much information as they need to about what's going on with them and what they need to be concerned about and worried about. So while processing speed and memory function change with age, it should be clear from the preceding discussion that these changes are not dramatically different from preceding levels. They do not interfere with daily living, and that they change gradually over time. These aren't, you know, marked, you know, rapid responses that you see. So this is a chart that looks at the difference between decline and dementia. And I want to go through each one of these cognitive tasks because this is how you might be able to distinguish what's normal aging, you know, from what is dementia. So learning and remembering, you may need more time and need to remember to focus on the task, but learning still occurs with age-related cognitive decline, whereas in dementia, people have trouble remembering recent events, conversations, and can misplace objects. Handling complex tasks. In age-related decline, there's more difficulty doing more than one task at a time. Like I said, you know, it's just harder to keep all those balls in the air. But with dementia, there's difficulty following tasks with many components. You can't serially follow a task. Well, that's not a problem with normal aging. In reasoning ability, there are changes not only to the extent that multitasking becomes more difficult. Older adults don't reason, you know, inadequately. They reason fine. There's not a problem with the reasoning ability. It's just that things just may take a little longer, a little bit more thought being given to it. But with dementia, people cannot respond with a plan to a hypothesized problem. So if you ask people, okay, now how are you going to give yourself these medicines? What is your plan? You know, people with dementia have a very hard time coming up and articulating a plan. Spatial ability and orientation changes. You see some changes with normal aging. There are all these "you are here now" maps in the mall and things. Those are very confusing for older adults particularly. Even more confusing for older adults than they are for me. And you know, I have to sit there and try to place myself spatially on the same place as the map and like, oh, okay, you know, here I am. Whereas people with dementia have trouble driving and organizing objects and finding ways in familiar places. So they can go out for a walk and not be able to find their way home. Or be driving in their neighborhood and break down in tears because they can't recognize their house. That's a very different problem, you know, than having slowing. That's a very different problem. Language. Words finding can be more difficult with normal aging. That's definitely, word finding has been demonstrated, been documented to be an issue related to age-related decline. But with dementia, difficulty finding words is pronounced, and people may often substitute words that don't fit, don't make any sense. Like asking an older adult why she had a bruise on her leg and just pointing to it, and she said, "Oh, my numerator," you know, and trying to, you know, identify specifically what it was that I was looking at. "Oh, my numerator." Didn't make any sense, but she was searching. Almost some expressive aphasia in appearance. And behavior may change. Older adults, I can promise you this, I'm starting to do the same thing. I don't see peripherally quite as well or whatever. I tend to try to take an easier route where I'm going. If I can make a right-hand turn, I will. I'm conscious of when traffic is heavy. I try to avoid heavy traffic. You'll find people saying things like, 2 wrongs don't make a right, but 3 rights make a left, you know? So there are things like that that you hear from folks about how they're changing their own patterns. That's because of normal age-related changes. Just harder to keep all those things in the air, manipulate all those things, easier to be distracted by irrelevant information, and some self-awareness because of the behavior changes that that's actually occurring. People with dementia may get more passive, or they may get more irritable. They can be more suspicious because they don't remember having put something in a certain place, and because they don't remember it, maybe it's because someone took it. Okay? So that's a very different kind of problem. What we see with the normal age-related decline are the kinds of things we see in our lives all the way through, you know, just maybe more consistently seeing them with age-related changes. Okay? With dementia, there are some very basic differences. Okay? So dementia can also coexist with delirium, which is acute confusion, and or depression, and that makes it very difficult because you may see someone whom you feel has dementia, but if there's also some confusion, a development of acute confusion on top of that, deciphering that and trying to help them with those things that are reversible and attend to those issues, you know, are really what you ought to be doing initially. So with dementia, the progression is gradual. With delirium, it's abrupt. It's an acute change. With dementia, there's a profound change. It's not age-related changes. There's a profound change. There's a fundamental difference in someone not being able to recognize their own home, okay? And in someone getting lost in an unfamiliar area. I can get lost in an unfamiliar area. And with dementia, it's hard for individuals to function independently. Hard to remember to take their medicines, which is something that I'm interested in. So forgetting in dementia is not only forgetting where you put the keys, which I do all the time, and I'm sure everybody does, you know, but rather it's about looking at the keys and not understanding what they're for, okay? And we've already talked about those other couple of things. Now, confounding variables it's interesting because our references for what's normal vary depending upon how much education someone has and how old someone is. So if people are coming from a low level of education, they may appear to have a lower mini-mental state exam because that's their norm references, you know, are lower. And that, you know, you can't necessarily use 24 as the cutoff for everyone. High levels of education, pre-existing education, can mask some changes. I've seen that also. You know, some very bright people who are experiencing some pretty significant change, but it's not picked up because they were so smart to begin with that it's taking a while for that to translate itself. Also, family tends to fill in the gaps. No one likes to hear, this pause or, you fill in the gaps for someone. I do the same thing. With colleagues, I do it. I'll finish a sentence, if I know them well enough and don't think they'll kick me out of the room. And it's also confusing for family because there seem to be periods of lucidity when family want to believe that everything is okay. I mean, we want to believe that. I want not to have to worry about my mother. I want to believe everything's okay. So getting on to delirium, which we know can be treated, is the development of acute confusion. It's a consequence of something has changed. So sometimes you'll see people functioning fairly well in their home environments. We admit them to the hospital, and it's a cause of delirium for them, that environmental change. Or an increase in their temperature, so if they have an infection. Or a change in their drug regimen, can throw them off. Adding new drugs. Polypharmacy is a cause of delirium in older adults. And to the extent that the confusion, that the change in cognitive function that we are seeing, that we observe, is due to those things that we can prevent or treat or be aware of, is very important. And this is one of the reasons why it's so helpful to have family along when people come in for care. Because if you have family, you can talk about, is this different than what what you're used to? Because you might see someone who has what you think is dementia, but they might be saying, no, they were fine, I don't know what's going on. This is one of the reasons I brought them in. But it's a little bit harder to identify that. Possible etiologies, infections, polypharmacy, we talked about that, hypoalbuminemia, so, poor nutrition, electrolyte abnormalities, a history of trauma. So sometimes people can have experienced a fall, they've got a subdural going on, we haven't recognized it for what it is. And sensory changes. So visual changes, auditory changes. If they're not taking in information, they can't respond well to you. It has nothing to do with their cognitive ability, but it can lead to increased confusion. So Inui, who's done a lot of work in this area, talks about vulnerability factors with delirium and also precipitating factors with delirium. And she considers vulnerability factors to be those things of advanced age, vision impairment, severe illness at admission, a pre-existing cognitive impairment. So if they have dementia, they're more apt to become delirious in the hospital because it's harder for people to interpret what's going on and to fit all those pieces together. Dehydration, and a serum creatinine greater than 18 milligrams per deciliter. Precipitating factors are things that we do sometimes to people. Physical restraints are absolutely forbidden in most work environments today, and yet they continue to be ordered because people just don't understand. Physical restraints really do prompt a irritable, anxious reaction on people's parts, and they've also led to falls and even death, trying to get out of the bed with the restraints on. Adding more than 3 drugs to the person's current medication regimen, these are things that you all know. It's just kind of put together in one place. And bladder catheter use primarily because I think it leads to infection, and any other iatrogenic event. So I'm introducing another concept here, depression. We'll be talking a little bit more about depression in just a second. But just to give you a table to compare dementia, delirium, and depression, it would not really have been appropriate for me to have put age-related cognitive decline in here because those are the kinds of normal things that we see that are gradual over time and they're developmentally appropriate. But in terms of onset, depression is often, you see, it can be weeks to months, it can be rapid. Delirium, hours to days, it's very acute. This is not a short-term, this is a short-term kind of onset. It's there. It wasn't there, it's there. Dementia can take months to years. It's slow and indefinite. Duration, with depression, it's short if people get treated, if it gets diagnosed and people are treated, and your treatment can involve either some of the cognitive therapies or some of the newer drugs. for depression work well with older adults as well as they do with other people. So it's something that, you know, we definitely should keep in mind that we can use. With delirium, the duration is variable. It depends upon how long we remain naive to what's really going on. Okay, how long that they have to deal with that. And dementia, of course, you know, it's long. It's it's a lifetime. Mood with depression is fairly consistent. It's fairly depressed. It's flat. Whereas with delirium, it can be labile, and there are fluctuations also with dementia. Whether or not people recognize their own disabilities. In depression, yes. I'm worthless, I don't care, you know, of course I can't do anything. With delirium, new disabilities appear. It's an acute thing, you can see it, it's happening. You know, when they come to you and they're already have delirium, it's hard to know if that's a change, but that's why why relatives are so helpful, or significant others. With dementia, people can try to conceal what's going on. It's a very frightening thing. It's not a pleasant thing to have to tell people that you feel that you're experiencing some permanent changes in the way you're thinking and remembering. People with depression often answer, I don't know, I don't care. People with delirium, you can ask them a question, they're incoherent. It's acute confusion. And people with dementia, they offer a response, but not always correct, but it may be close to correct. And the mini mental state exam, which we know that is one of our things to kind of try to help us. All of you familiar with the mini mental state exam, has a 30 score on it. There are others that are used, short portable mental state questionnaire. The Blessed is another one that's used. Performance with people who are depressed can fluctuate depending upon, you know, what they're feeling at that time. With delirium, there are acute fluctuations, and with dementia, there's a fairly stable downward trajectory over time. So with, in terms of progression, depression can resolve with treatment. It's amazing what drugs can do to help people. And delirium resolves with treatment if we identify it. That's why deciphering the 4Ds is so critical, because you have to be able to figure out, well, what's going on here, and then treat what's appropriate to treat. And then with dementia, it's ongoing. But also with dementia, I think it's important to remember that that the progression is ongoing, but could be potentially helped by some of the newer drugs that are coming out. So, you know, we need to keep some of this ability to diagnose people earlier, I think, will be very helpful in terms of treatment. With depression, the incidence is common among older adults. About 20 to 30% of people that you will see in your clinics, in your hospital settings, in the community will be suffering from depression. Think about it. Being old, incurring older age is filled with loss. Loss of friends, loss of home potentially, loss of a spouse. A lot of losses, and losses can lead you to feel depressed or down. Symptoms, I use my friends, this is Terry Badger's mnemonic, Ziggy caps. It stands for sleep disturbances. These are the symptoms that you'll see with folks: lack of interest, guilt, reduced energy, difficulty concentrating, appetite changes, psychomotor disturbances, and suicide attempts. Okay, so Zig caps. Memory deficits may be the presenting symptom for people who have depression. They complain of a lack of ability to concentrate, inability to focus attention, problems learning new information, just do not care, and speech can be slowed. So it's important to try to distinguish if that's what's going on. Now finally, just for some history and physical examination guidelines, interview people alone at first, and then ask the patient if others can be interviewed, if the family or friends can be interviewed. And make sure that the patient can hear and see adequately during your exam. That's a real problem. You can misinterpret that someone doesn't know what's going on, and it's because their vision has changed. And they haven't identified it either, because it's changed slowly over time. Assessing functional status using one of the functional status instruments. You know, hopefully, I don't know, you know, if we can get people a copy of the PowerPoint potentially so that they can use these websites. to look for functional status instruments. There are other instruments available on the web that can be drawn up as well. In terms of history, the assessment should include conditions that may cause cognitive changes, like chronic disease or head trauma. Also assessing baseline cognitive functions, level of consciousness and duration of changes, your ability to perform activities of daily living, and your ability to perform instrumental activities of daily living. Lots of providers who don't normally work with older adults do not consider this part of the exam, and it really is for older adults. We need to be more sensitive to those kinds of things, which we can then will lead us to being alert for things that can prevent downward trajectories. Also asking about what pills they're taking over the counter, shared and prescribed medication. Shared prescriptions are very common. The older people get, the less they feel like they have to deal potentially with some of the, okay, you told, you know, I take this for sleep, so, you know, you might want to use this for sleep, you know. Some of the rules start to slip a little bit. And alcohol use. We need to, you know, consider that as well. Obtaining a family history, talking to family about any incidents of delirium, not saying it like that, but episodes of acute confusion, what they might be related to, depression and dementia. We have Don Royal on our campus here who's developed a method of scoring the clock. A clock drawing is an easy way to get an indication of someone's cognitive ability. Basically, what you ask them to do is to draw a clock so that a child could read it, draw the hands and face, and I think it says point it to 1:45 or draw it so that the hands are looking at 1:45 or something like that. And he has a scoring criteria that helps you identify whether or not someone would be considered mildly cognitively impaired. And determine educational level to assess if the results that you're seeing, if the conversations that you're having and behavior are consistent with their educational level. So someone who, you know, is a PhD prepared person, you know, and you're talking to them and you're feeling like, you know, this person is really not connecting, that's a significant change. Someone who traveled a lot and could make their own plane reservations and now can't, that represents a change. That's not normal age-related cognitive decline. Normal age-related cognitive decline is getting on the phone now with pencil and paper and then having to go get something else because you forgot to bring it to the phone with you while you're on the phone with the reservation person. Other kinds of things where you just can't do it anymore, don't know how to do it, can't plan it, can't execute it, that's not normal. Obviously, you know, a complete neurological examination is important. Also get a complete blood count with differential serum chemistries, albumin. So we know that electrolyte imbalance can lead to acute confusion. Urinary post-void residual, just looking at whether or not someone might have a bladder infection is very common in older women. We tend not to pick up on it. You know, infections with consequent temperature elevations can lead to acute confusion. Chest x-rays, walking pneumonia is not uncommon among older adults. EKGs, pulse ox, and arterial blood gases, when it's warranted, I certainly wouldn't go out and get those on everybody. And consider additional tests based on your preliminary findings, you know, like as you try to narrow things down. I think that these things are fairly well established in terms of the exam. It's just things that, you know, we need to take a look at specifically related to this. Rob, where are you? I'd like to have the PowerPoint turned off at this point. So I'm wondering if all of this makes sense to you, if you have any questions. I did want to refer you to, there's an article that came out last month in the Journal of Advanced Nursing. It's volume 38, and you can get this. I can leave a copy with you, and you could possibly get that copied for people. Do you have any questions? Yeah, you're welcome. Rob, where's my audiovisual person? I wish when we're doing this long distance kind of thing that, you know, people can actually interact. Oh.
It is interesting.
Oh, okay.
It's just that during the summertime, it's
Uh-huh.
hard to get the sites, they're either at vacation or they're this,
Yeah, yeah.
that. But during
Thank
the
you.
regular time.
Nothing. We got the picture on now, that's all I wanted. So any questions that I can respond to? Anything come to mind?
No, I think it really helps the, age-related, looking at age-related and then comparing it to the dementia, because people do tend to
Yeah.
kind of panic and,
Yeah,
think,
yeah,
oh no,
yeah.
especially if you have older parents,
Yeah.
or whatever.
Yeah.
But, I mean, that was very well clear, the way
Yeah.
you presented it.
Thank you, because I think that one of the things that I find is that people start to get scared.
Mhm.
Because they
Exactly.
do see that there are differences in the way they're thinking and remembering compared to younger years, and they start to think, well, this must mean
Yes.
I'm getting Alzheimer's, and that's not the case at all. There are some things that normally change, just as there are changes in our skin, there's got to be changes in the brain that affect, our ability to do things as quickly, processing speed. Sensory input, is very important. We just don't see as well, eyes get cloudy with cataracts and lens shortening, and things just change. So I think it's very important for people not to get frightened about those changes, because that doesn't mean that they have Alzheimer's, and it's a very different kind of thing. Good point.
But, you've heard so many down things about dementia, here I am. But, and Alzheimer and so forth, that you think, oh no, it's almost a constant fear to where you just think, uh-oh, every little slip, did I lose my keys?
Yeah.
Oh dear, it must be,
Yeah, well, I certainly misplace my keys all the time. There is, some of you know, or I'll tell you that I work with, I'm interested in medication adherence, so one of the things I'm interested in is whether or not people remember to take their medicines, and how that gets difficult as time goes on. And not only remember to take the medicines, but remember if they did take them. Because, it's, did I take it today, or do I remember taking it because I've been taking it every day? This happens to me all the time.
Yeah.
And I think that there are things that we can do to help normal age-related changes as well. But one of the things that's been clearly demonstrated is that the level of busyness helps us to predict who's going to have trouble with adhering to their medicines. So the busier you are, the more likely you are to forget to take your medicines. Okay, that's been demonstrated. And who are the busiest people? People in their middle years. They tend to be the busiest people, and they tend to be the people who are more likely to forget their medicines. So. Anything else come to mind? We're looking at about, I guess about 4:45 or 10 to 5 right now. That's fine.
But middle years though, it's gonna be hard to pinpoint what are middle years, because if someone lives to 50, middle years were earlier. If someone lives to be 80, how do you define?
Well, middle years, I tend to think about 40s and 50s and 60s as middle years.
Oh, good.
And really, we don't see the kinds of changes that I'm talking about with age-related changes until after 65, and then they're not dramatic until after 75. You really don't see, I don't see anything really striking in people as a general rule until after they're 75. And that's one of the reasons why in the work that I do, I look at people who are at least 70 years old or older. Because it's really, you just don't see it. And in fact, I'm trying to get a even more frail population. I like getting people who are in their 80s. They're living independently in the community, and in their 90s, and they're able to do it well. Well, what's that all about? I have people who are 68 who are having a harder time. I'm more concerned about than people who are 93 in my study. So age alone is not a good predictor of ability to provide self-care. And having a supportive environment, I think, is one of the things that I'll be looking at in terms of nursing interventions that can help people stay independent. If we can keep people independent, it's going to have two very profound and important outcomes for us. It's going to decrease the cost of providing care for my generation, my baby boom generation, since by 2030 there will be only 2 workers available for every beneficiary of Social Security. That's a very expensive burden for our young people. And secondly, quality of life issues. I have yet to talk to people who really like that apartment model. No, they don't want to move into an apartment. They want to stay in their own homes. They know their neighbors. They know how to get to the grocery store. They know the pharmacist down the street, you know, and people will help them out. They know these folks. They have a history with these people. So the apartment model hasn't worked well. So as nurses, if we can figure out ways to help people stay independent, I think that that'll be very helpful too. Okay.
Age in place is what they called it.
Mhm.
Aging in place.
Yeah, I've heard that, yeah.
Because you are familiar and it takes less time to have to think, well, where is this and where is that? It just minimizes the things they have to think about because they are so familiar.
The time and the effort, because if you go to a grocery store where you know where they have this and where they where you walk to this
you
and that to the other.
don't have to use so many working memories.
It doesn't take so long, but if you go to a new place, you have to figure out
Where
which
it
aisle do
is.
they have this, which
Yeah.
aisle do they have that,
Yeah.
and it takes more time.
Okay, well, it was really good to be here.
Thank you.
Thanks for your time. Have a good evening.
You too.